That is sponsored by MSD. I invite Dr. M.V. Chandrakant, again, a consultant medical oncologist, Narayana Super Specialty Hospital, Kolkata.
Thanks, Dr. Hollis, and thanks organizers, and I would also thank Merck for the opportunity. I'll just check whether the slides are moving. If not, I'll ask the organizers to. Okay, it's not moving. Okay, so can the organizers share from your end? I'll keep saying next. Well, in continuation to a brilliant talk by Dr. Vijay Patil, saying how important is survival in lung cancer, apt to the definition is redefining survival outcomes in non-small cell lung cancer, and I will be speaking on pembrolizumab. So we have two landmark practice-changing trials of chemo-IO combination, chemo-pembro combination, and that is Keynote-189, addressing the non-squamous non-small cell lung cancer, and the Keynote-407, that is a squamous cell lung cancer. Next slide. Keep moving. No disclaimers. The slides are provided by Mark. Okay, so this we have discussed. Okay, next slide. Okay, so there's a high conversion to mortality in lung cancer. However, as we see, the 5-year survival mark has been reached. So it's becoming a more of chronic disease. Next slide. So this is the treatment options we have in lung cancer, and smoking cessation becomes one of the most important point. And we can even give systemic therapy to performance status 2 patients. And we have chemo, IO, TKI, all these are the options we have. Next slide. Next slide. So this is the ECOG 1594. It was published in 2002 that said that all platinum-based doublets are feasible. So the standard treatment is platinum-based doublet chemotherapy in 2002. Next slide. So you can see all the 4 platinum-based doublet equally do well. Keep moving. Next slide. So this is the BMJ 1995, where it said that the meta-analysis said that the absolute benefit of chemotherapy in non-small cell lung cancer was around 9 to 10%. So there is improvement in overall survival in terms of 10% if you give systemic therapy in the era of chemotherapy in 1995 and then around 2002. Next slide. So what we know about chemotherapy? So no survival benefit when we use triplet instead of doublets. The platinum-based doublet was the standard treatment, and then platinum-containing regimens are better than non-platinum combinations. Cisplatin is better than carboplatin, only in certain subgroups like stage 3B and in non-squamous variety. Otherwise, cisplatin and carboplatin are comparable, and whether 4 cycles of platinum or 6 cycles of platinum doesn't have any difference. Next slide. So this is the Scagliotti paper saying that for adeno it is PEM platinum and for squamous it is GEM platinum. Next slide. Okay, keep moving. Next slide. So well, we all know that cancer is an immunosuppressive disease. It has its own ways of immune addition and altering the immune system in favor to it by expressing PD-L1 or by releasing chemicals that suppress immunity, increasing Tregs, and so on. Next slide. So this is important. We can understand that if we give IO alone versus IO chemo combination, so an immune cold tumor where we have more Tregs, less CD8 cells, and less APCs. If you use IO alone, this cold tumor can be converted to a hot tumor that is susceptible to immunotherapy by adding chemotherapy. So chemotherapy reduces Tregs, increases CD8 plus T cells, increases APCs, and increases antigen presentation, rendering it susceptible to IO-based therapy. So it increases PD-L1 sensitivity. That's what chemo-IO combination does. Next slide. So I will speak on 189. Next slide. So 189 is a phase 3 study. Before this, we had a phase 2 randomized trial, and now this is the phase 3 Keynote-189 study, 4-year follow-up. This is in non-squamous, non-small cell lung cancer. So no driver mutation, EGFR negative advanced lung cancer, irrespective of PD-L1, no prior treatment. All these were, and no active CNS mets. These were the inclusion criteria, and it was 2:1 randomization, 400, 200 each arm. It was randomization was pemetrexed platinum plus pembrolizumab, 4 cycles, or pemetrexed platinum plus placebo. And then if there was response to stable disease, it was pemetrexed maintenance in the standard arm or pembrolizumab plus pemetrexed maintenance. And it was continued for up to 2 years and so on. And there was around crossover was allowed in this particular study. And you can see the baseline characteristics. They were all well matched. You can see majority were smokers, and Asian population were less in this particular study. Both cis and carbo was used. Next slide. Okay, keep moving. Next slide. So you can see the study met its primary endpoint, and the 4-year overall survival is what we speak of, and the median overall survival was 22 months, nearing 2 years median overall survival. So as Dr. Vijay was saying, it is not the median we have to see, we have to see the tail of the curve, and nearly 20-30% patients have long-term survival crossing 4-year mark. Next slide. So if you have a higher PD-L1, that is PD-L1 more than 50%, the responses are more magnified. These are highly positive results. You can see the positive results in both all the 3 subgroups, TPS more than 50, TPS 1 to 49, and TPS less than 1. In all of them, you have impressive hazard ratios of 0.5, 0.6, 0.7, and statistically significant improvement in overall survival, even in the TPS less than 1 patients. Next slide. So this is the progression-free survival. Again, if we use chemo-IO combination, the PFS is maintained, unlike IO monotherapy. Next slide. There's doubling of progression-free survival. Keep moving. So again, the PFS. So this is a wonderful forest plot looking into which subgroup benefited. You can see almost all the subgroup benefit, including PD-L1 less than, or the TPS less than 1%. So the magnitude of benefit was more if it is more than 50%, but all the subgroups have benefited with IO chemo combination. Next slide. So this is the PFS2. So the durability of IO responses and efficacy, you can see even the PFS2 is better in the IO chemo arm compared to the chemotherapy arm. Next slide. So the PFS2 is better irrespective of the amount of TPS expression, highly positive study. Next slide. The responses are of course better if you use chemo-IO combination. Again, if PD-L1 is more than 50, the responses are in terms of 60%. Next slide. Keep moving. So this is the 2-year OS rate. Those who survive 2 years, they have a nearly 80% chance that they will survive longer. So if you've crossed the 2-year mark, and you can see those who have long-term survival have nearly 75% response rates. So those who benefit are going to benefit, and they have very durable response, and chances of they crossing 4 years is phenomenal. Next slide. So there was an effective crossover, more than 50% crossover in the chemotherapy arm. In spite of crossover, the overall survival was maintained. So we are dealing with advanced lung cancer, and there is high chance that there are a significant number of patients, the chemo arm may not even go to IO arm. So therefore, it matters by exposing these patients to IO as early as possible in the frontline setting. Next slide. These are the grade 3, 5 adverse events. We know that IRAE grade 3 are seen in just around 10 to 12% patients only. Next slide. Next slide. So hypothyroidism, hyperthyroidism, rash are the ones that are more common in PD-1 inhibitors. Next slide. So pneumonitis is quite rare. Colitis is rare when you compare to CTLA-4 blockers. Keep moving. Next slide. So the takeaways are, with the 3 years of follow-up, pembro plus pemetrexed platinum provide OS PFS benefit versus placebo. 3-year OS rate doubled with pembro chemo. OS and PFS were improved irrespective of PD-L1 expression. Therefore, in non-squamous advanced NSCLC, pembrolizumab plus pemetrexed plus platinum should become the standard of care in all patients irrespective of PD-L1 expression. Next slide. So let's quickly go through the squamous data. Keynote-407. Keep moving. Next slide. Similar patient population, squamous has worse prognosis than non-squamous. You can see the improvement in squamous is not that great because they don't have driver mutations. Next slide. So this is how, again, 1:1 randomization. Here they have used Pacli or Nab-Pacli with carbo with pembrolizumab 4 cycles, followed by pembro maintenance versus placebo maintenance. And crossover was allowed in this study. Next slide. So baseline characteristics, majority was smokers. That's what we can look into. Keep moving. Next slide. So you can see the overall survival. The study met its overall survival endpoint, 11 versus 17 months in the intent to treat population, hazard ratio 0.71. Next slide. So if the TPS was more than 1 or less than 1, you can see the hazard ratio was phenomenal. However, if it was less than 1, it crossed unity. Next slide. So this is the PFS data. Again, when we're using chemo IO, the PFS is better than the chemo monotherapy. Next slide. So the PFS, irrespective of PD-L1, more than 1 or less than 1, the PFS was better. However, it was more pronounced. The PD-L1 was more than 1%. Next slide. Again, you can see the better responses being there in the chemo IO combination arm. Okay, next slide. So this is the duration of response. So IO is the winner. When you look into duration of response or durability of response when compared to PFS. Next slide. Almost doubling of duration of response. PFS2, so there is spillover effect or the efficacy of IO goes on even to the second line. That is PFS2. Next slide. Okay, irrespective of TPS, PFS2 is better. Next slide. This is when you adjust for crossover, you can look into the lower down. The orange one is if you adjust for crossover, the overall survival is much more pronounced. And even if there is crossover, the overall survival is different in the Indian treat population. Next slide. So adverse events, I think we discussed, it was in par with what we discussed before. Keep moving. Next slide. Next slide. Yeah. So the takeaways with that, with 3 years of follow-up, pembro plus carboplatin and Pacli versus Nab-Pacli continued to provide overall survival and progression-free survival benefit versus placebo versus chemotherapy versus placebo plus chemotherapy in patients with previously untreated metastatic squamous cell non-small cell lung cancer, irrespective of PD-L1 expression. And those who completed 2 years would live longer, and the chances of they having long-term survival is better. Therefore, taxane plus platinum plus pembrolizumab should become the standard of care in all patients with squamous cell carcinoma, irrespective of PD-L1 expression. Right? Last 2 slides. Okay. So this is specifically addressing a pooled individual patient data analysis of PD-L1 0 or less than 1%. Is there a benefit of chemo combination? Next slide. Okay, so they've combined all the 3 trials in specifically addressing the subset of TPS less than 1%. Next slide. So you can see if you look into TPS less than 1%, So if you pool the individual patient data analysis of all the 3 trials, there is statistically significant improvement in median overall survival, hazard ratio of 0.63, 0.5 to 0.79 being the confidence interval. Again, significant improvement in overall survival, even in the absence of PD-L1 expression. Next slide. The PFS also is better, even in low PD-L1. Next slide. So PFS2, PFS, and OS all are better, even if the TPS is less than 1%. Next slide. Overall responses are better, even if the PD-L1 less than 1%. We can see doubling nearly around 60% improvement in response rates if you add IU. Next slide. Okay, so I would conclude that in patients who have non-small cell lung cancer, whether it is squamous or whether it is non-squamous, chemo-IU, pembro plus platinum-based doublet combination should become standard of care in all patients, irrespective of the expression. Thank you, everyone, for patient listening.
Thank you, Dr. Chandrakant, for the detailed talk. We now move on to the